A number of demonstrations and programs are pointing toward a better future, leveraging home health and home-based care, and many with positive results. These projects and programs include the Independence at Home Demonstration Project and the Veterans Affairs Home-Based Primary Care Program, Medicare's program of all-inclusive care for the elderly, or PACE, as well as accountable care organizations, bundled payment arrangements, and community-based care transitions programs, all making very good use of home health and home-based care. These are merely harbingers of future change. I'd like to note, too, that in addition, the Institute of Medicine and the National Research Council held a workshop in September on the future of home health care, taking up these very issues. And I would encourage you to take a look at the video and the presentations that are on the Institute of Medicine website. The workshop summary will be released early next year. The Alliance supported that workshop as part of a larger Future of Home Health project that we are pursuing that is really about trying to improve understanding of the future of home health care and the healthcare system so that we can optimally support our older Americans and our Americans with disabilities. And we're really seeking to try to clarify that vision for the future and to identify the key needs to be addressed in terms of workforce, technology needs, research needs, quality measurement needs, policy needs. In conclusion, I'd just like to say that the Alliance and its members stand ready to work with policymakers and other healthcare stakeholders to support solutions that will improve healthcare in America. And I look forward to this panel discussion.
Thank you very much. Ms. Jackson?
Thank you and good afternoon. I think I'll just start by level setting a little bit and giving some background on Walgreens, just for folks who are not as familiar with the company. So Walgreens began in 1901 on South Side of Chicago, and we're founded by a pharmacist, Charles Walgreens. The store has since grown to be the nation's largest chain drugstore with over 8,200 stores spread across the 50 states as well as the U.S. Virgin Islands. 63% of our stores, our stores are located within 3 miles of 63% of all Americans, 75% of African Americans, 78% of Latinos, and 65% of our stores serve medically underserved communities that are in desperate need for access to care. As we look at our model, we try to provide care in a convenient way so that people have an access point into the healthcare system, which we feel is invaluable as people continue to enroll in coverage. We have more people enrolling under the Affordable Care Act. Now we just need to make sure that they actually have access to care and we provide enough entry points for care for them. So as we continue to look at healthcare, we believe that there are valuable opportunities to improve the efficiency of our system through increasing access points to care and through better integration of care for all of the healthcare professionals that are currently in the system, including pharmacists, into care delivery teams. As we continue to enroll more Americans in healthcare coverage under the Affordable Care Act, the need to utilize all current healthcare professionals also increases, including pharmacists, including nurses, including other practitioners, to make sure that people are really practicing to the top of their education and training. Care should also be convenient. Studies will show that coverage alone does not result in people getting the care they need, especially for preventive services. So we need to continue to ensure that we have adequate points of entry into the healthcare system. We also should continue to look to explore ways to make sure our system is as efficient as it can be, and that we're reducing healthcare costs and improving quality of care. One such example would be to explore some additional payment reform incentives around medication adherence. As we know, the overwhelming majority of healthcare costs are spent managing and preventing the consequences of chronic disease. Prescription drug therapy is at the cornerstone of management of chronic disease. However, we spend nearly $300 billion annually on non-adherence to medication regimens for possibly unavoidable or possibly avoidable healthcare services. So as we continue to look at that, we should look at ways to address medication adherence. And we also need to continue to explore, again, the convenience aspect of care. There's a lot of discussion around telehealth, and so how do we create a national dialogue and a national strategy around that to, again, make sure people are getting the care that they need. And sites of care are going to be continue to look different than they have in the past as well. One of the businesses that we have is home infusion, and so we provide infusion services at a lower cost site of care, which is in people's homes. And so we'll continue to see some of those changes as well as our system transforms and as more people come into the system. So really continuing to develop strategies around that to get people the care that they need, where they need it, in the most convenient way.
Thank you very much. Mr. Santi?
Well, a lot was just said, so I'll keep this really brief so we can start the conversation. I would say we are right now, from the perspective of a congressional office, in a new chapter for how healthcare will actually be delivered and paid for in this country. And that's ultimately Congress's role. We think long and hard about how we pay for services that better control costs, but also improve the lives of constituents. And right now, I would say the U.S. healthcare system is at an interesting break. Where we were paying for services just on volume, we are now starting to have larger conversations on value. We were also ostensibly a two-tier system. If you could pay for it, you could get access to the care that you needed or actually sought out when you're talking about preventive services. But now, with the onset of the Affordable Care Act, the expansion of Medicaid, and some transformative work being done in the states, we are seeing that barrier broken. I would say from the perspective of Illinois, we have a long way to go. Right now, 50% of births in the state of Illinois are paid for by the Medicaid and CHIP program. A lot of those happen in very urban and very rural settings, so access to care may not be, for neonatal specialties or things like that, that prevalent. We also have to think about sites of care and the workforce. So I'm doing this at the 30,000 foot level at the Congressman's request. We can get into this a little bit more too. It was touched on upon here. When we think about access of care, are we really talking about hospitals anymore? Are we talking about community health centers, urban health centers? Are we talking about clinics? Yeah, we're talking about all of those and then more. And the integration by which a hospital may not be the hospital that you think of, but place this four-sided building with inpatient beds, is now transforming almost into a site of service for your everyday needs. And I think there are pillars in communities that have to start to get rethought as people live longer, have now access to insurance to go pay for that care, and getting an assessment of what their health needs overall are. I'd say for Congress, we are in a pretty precarious time going into the next year. Congress has to reauthorize the CHIP program, a highly successful program that will be tinkered with and we will have a full debate on. Congress has to reauthorize the Community Health Center program. Community health centers are the vital backbone of healthcare delivery, not only in Chicago, that I can speak of, I'll speak in Illinois terms, they know it the best, but also downstate. When we go to communities with less than 1,000 people, there are community health centers in there. Are they staffed with behavioral health? Are they staffed with prenatal services? Probably not. So we have to think about growing our network of community health centers. And then finally, I would say no two hospitals are alike. And those hospitals vary by geography and the population that they serve. The next thing we have to do is the Teaching Health Center GME program. We have to grow our primary care workforce. And we're not doing a very good job of that. A lot of that flows through not only how much we invest in people getting through medical school and what we're tracking them to do, but the incentives in our system to push them towards specialty care, which we can talk about a little bit more, and how Medicare does that. The National Health Service Corps, there are physicians out there that want to do good and want to work in underserved communities. It's a program that's been around for decades that, by and large, is incredibly popular, but we can't take all the qualified applicants that we really want to. I wish we could grow it. And then finally, I think we have to rethink on the Ryan White program, though the HIV/AIDS community has been really active in getting funding for it without having to go through the drama of having to debate it, which I applaud them for. So I would say right now, how we pay for care, keeping up the system for programs that work, like CHIP, and how we access that care Congress is going to have a very big role in it, and that debate will, I would say, will become very loud and very vocal over the next coming weeks. So I'll take questions on that.
Great, thank you so much. So if I could summarize, I think what we've heard from the panel are some outstanding remarks that talk about the transformation of healthcare, transforming it from a sick care system to one that promotes prevention and wellness. We also heard the panelists talk about the need to build up community-based infrastructure to be able to support individuals outside of the healthcare system in their homes and in their communities. We heard the need for payment reform around medication adherence, primarily because what we're seeing are the results of individuals who are not receiving the appropriate care, be it because of issues related to their own negligence or adherence, issues that are related to cultural or social or economic issues. But the bottom line is that we have a large number of individuals who are now suffering from preventable chronic diseases or their consequences as a result of that. And that is costly both in terms of money and in terms of life and quality of life. And finally, we heard about the transition from a healthcare system that pays for volume to one that pays for value. So there are lots of pieces to the healthcare system that are beginning to be brought together, as we heard from the panelists. So I want to open up questions to the audience. I think there's a microphone over here in the back of the room. I'll start out with one question just to get us started, just related to those pieces of the healthcare system that we're trying to bring together, and this is for all the panelists to respond to. A lot has been made and a lot has been discussed with regard to care coordination or providing coordinated care, which certainly addresses bringing the fragments of the healthcare system together. Can you guys talk about what your organization's role has been and what missing links exist that we need to begin to think about to better coordinate care for individuals? So I'll open that up to the panel.
I was volunteered. One of the things that nurses are beginning to participate in discussions with their workplace, whether it be in the hospital-based setting or the outpatient-based setting, is the need to change from a silo-oriented approach to care to a transitional continuum, and which includes the acute care into transitioning to the appropriate time and place and the most cost-efficient way to the next level, be it inpatient skilled nursing, acute rehab, or into home care. More and more we're trying to educate the health delivery system, the importance of home care, and also in teaching the patient, the family, so that they can reside in a quality of life in their home setting, and following up. And most recently in the past few years, and there's a lot of debate and discussion on this because not everyone has embraced it, and that is the Accountable Care Organization and Patient-Centered Medical Homes. And the organization that I work for, it has been very successful because it helps to reduce readmissions. It also helps to coordinate that care, and the nurses are embedded in the clinics to assist the physician in ensuring that that patient not only gets the care that they were prescribed upon discharge, but also in the continuing to capture those where there's opportunities to do some interventions in closing gaps, and then to ensure that the disparity is removed. For example, the diabetics. That is a critical one, because if you can manage diabetes through control, you are going to reduce the cost and those hospitalizations and those readmissions into the hospital setting. And so we have what we call population management strategies as well.
My organization has done a lot of work that sounds very much in line with what Deirdre just described. And one specific thing that we've developed over the last year is something that we call the home health model for care transitions. And it's basically a home health specific care transitions toolkit and set of resources that I encourage you to check out. It's available on our website. I see Sarah Bogdan from VNA here. Her organization as well has done a great deal in the context of what they call their blueprint for excellence. So I think that there are many home health organizations that are really trying to propel improvements in the context of care coordination that are really at that sort of grassroots level of improving the quality of care on the ground running by providing tools, resources, and education, putting them in the hands of providers so that they can take it and really run with it to improve quality of care and care coordination. On a larger level, as I mentioned, I think that from a policy standpoint, we absolutely need to be addressing alignment of incentives through some of these healthcare delivery system reform models that, granted, are being tested, but are starting to point the way towards real progress in our healthcare system. And I think the challenge there is that we have a lot of experimentation in a lot of different models, and we're evolving as a healthcare system, to Srinu's point. And whether it's ACOs or bundled payment arrangements, the Independence at Home demonstration, or community-based care transitions programs, I think that what they all have in common is that we're starting to put providers and groups of providers that are really in sort of healthcare systems at risk and holding them accountable for outcomes, and really trying to do so in the most cost-effective manner. And I do think that that's going to be a pathway towards reducing fragmentation and improving coordination of care over the long run.
Thank you. We're doing a number of things. I think I'll start with just kind of internally with our omni-channel, looking at touching the patient not just when they are in our stores, so not just the bricks and mortars, but continuing to provide care once that patient actually leaves the pharmacy. And so we do that using our mobile network, and so we can send you can sign up to get pill reminders, which helps people adhere to their regimen, to let them know it's the time of the day where you should be taking X pill. You can have reminders for pill refills. We also have a mobile app that allows you to scan your pill bottles for refills and then pick them up at the pharmacy. We also provide a 24-hour pharmacist hotline where someone can call in and be in touch with a pharmacist. And we most recently announced a partnership with MD Live, where our mobile users using the Walgreens platform can also have access to a board-certified physician for a consultation 24 hours. And what we're seeing is, again, with sort of convenience and being at the heart of some of this and using technology, people really being able to access care in a way that's more convenient for them. We're also doing some things in line with what I've heard from my other two colleagues on transitional care. And so for us, it's making sure that we help patients who are exiting a hospital manage their drug regimens once they leave. And so partnering with hospitals as well as community-based providers for transitional care programs, where we identify patients that are most at risk for non-adherence, do screenings with them and consultations. We also will provide their first 30-day script and deliver that to their home, and then have a pharmacist follow up with them to make sure that they are understanding their new drug regimen and following the program and working in concert with either the hospital or community-based care provider.
I think most people get the idea of what care coordination is. I think most people can understand that you're not going to see, for any acute episode, you're not going to go to the hospital for that one service and then be discharged and then not have that follow-up, or however you want to do it. I think people get the notion that there's a team of people. If you're talking about care coordination in your medical home is often your physician's office, and they can refer you out, but they control your records. I'd say one thing that's been at the forefront of this debate is how we share information. Right now, I would say that there's a strong push by physicians. I know this has been recorded, so they already know this because I have to tell them this. That a foolish notion that they should be upgrading their information and IT systems so that they could actually maybe send an email, maybe not a fax, to a hospital. There are doctors that still don't use computers in their offices. You've probably been to them. And there are hospitals that don't talk to hospitals down the street. And there are hospitals that don't talk to doctors. And there are hospitals that don't talk to SNFs. And that patchwork not only exists across the country, it exists in neighborhoods in Chicago, it exists in neighborhoods in Peoria or in New York City. And it's ultimately up to the payer to perhaps rethink how we incentivize that. So we've done that. We've changed how we code for physicians. Said, you know what, we've got to rethink how you input data so that we can further see what diagnoses are being utilized and what Medicare is actually paying for. To this date, that's been delayed probably for about 3 years. We've also put in a lot of incentive dollars into hospitals for them to upgrade their IT systems. I would say the hospitals, by and large, have done an incredible job of actually taking what is ostensibly one health system in Wisconsin told us it cost over $480,000 to redo their entire IT, and they're not going to see any of the money back. So then why would you do it? So if you are a forward-thinking health system, you would do that. You would say, okay, if I'm MedStar, if we're all in DC, and I have Georgetown, and I want to connect with MedStar, say, in Fairfax or whatever, you could do that within the health system. But thinking more broadly about the Medicare population and the Medicaid population, utilization of hospitals and physician practices could vary. Some people might want to, maybe haven't settled on it on doctors. Maybe they have an acute care episode at a hospital across town. They just get shipped over. Maybe the hospital picks them up at home, ambulance picks them up at home and sends them some other place. Those facilities have no ability right now to talk to each other, even though right now everyone has more technology than they do on their iPhone. And that ultimately is the tragedy of it. So I would say before we get to a point where we have a scaled model of what it is that's ideal for delivering care coordination, we ought to think about investing. I think the federal government has a major role in that, or the senator does for sure, in helping our providers just communicate. I actually had a conversation with a family practice doctor in rural Tennessee who said he still has to fax paperwork up a hill to a hospital and then oftentimes walks it up the hill to the hospital. For a person that actually has to have an acute episode, probably a heart attack, probably some orthopedic pain, but can you imagine the system has failed that patient, and that doctor is limited by his own resources. So I think we have to think a little broadly about it. And also we have to think that care is not only delivered in the Upper West Side of Manhattan or the Gold Coast of Chicago or in Beverly Hills. It's delivered in urban communities and rural communities that often have long distances between access points. So I think